Good afternoon, everyone. Welcome again to the McLean Hospital Borderline Personality Disorder webinar series. My name is Chris Palmer. I'm the director for the Department of Postgraduate and Continuing Education here at McLean Hospital. I'm also a practicing psychiatrist, and it's my pleasure to welcome all of you tonight. Tonight's webinar is on the family involvement in the treatment of borderline personality disorder, and our guest speaker is Dr. Joe Flores. Before I introduce him and before we get started, I have a couple of logistical announcements to make. First, all of our webinars are being recorded and are archived on our website. If you look in the lower left-hand screen, you'll see a lot of web links. That very first one, titled BPD Patient and Family Education Initiative website, has links to all of our archived webinars. So if this is one of your first times, or if you haven't seen some of our other webinars, feel free to go to that site and view some of our past webinars. Secondly, tonight's webinar is going to be primarily interactive. So we're really hoping that a lot of you have come with questions and challenging situations that you're facing regarding borderline personality disorder and family involvement. So we're going to be looking to you to ask us a lot of questions. But to maintain all of your confidentiality, your microphones have been muted, and no other participants can see your name or email address. So in order to ask questions, I want you to look down at your lower right-hand screen, and you should see a box with Q&A at the top. So that stands for question and answer, and you will type in your questions there. I will be moderating, and we will get through as many of the questions as we can, and I'm looking forward to a fruitful discussion with all of you. The third thing I want to kind of make a point about noting is that this series has been brought to you by a philanthropic gift from a family affected by BPD. So that's why we're able to offer this for free. But we do want to be able to sustain this going forward for many years to come. And so if you have logged on more than once, even if this is your first time joining us, if you find this to be a valuable resource, I'm going to ask you to at least consider making a small gift to help sustain this series going forward. We have funding for over 2 more years, so there's no dire need right now. But again, every little bit helps. So even $5, $10, $20, anything would help. And if you want to make a gift, you can click on the link that says support these webinars, again, in the box of web links. If you do want to make a gift to this webinar series, please select not the McLean Fund, but select other when you decide to make a gift. And please mention BPD webinars. So mention these webinars so that your gift will be directed to the right place. But again, these are free, no pressure, no need to make a donation if you're not in a position to be able to do so. The next thing I want to announce is that our next webinar is coming up soon on May 12th. Dr. Judith Mintz is going to be talking about the symptoms of borderline personality disorder in adolescents. So if this is a topic of interest to you, you can actually register for that webinar right now or immediately after this webinar. And again, the link for that registration is in the list of web links. So without further ado, it's my pleasure to introduce Dr. Joe Flores. Dr. Flores is the medical director for the Gunderson Outpatient Treatment Program here at McLean Hospital, which is an outpatient program specializing in the treatment of borderline personality disorder. He's also an instructor in psychiatry here at Harvard Medical School, and again, he's going to be speaking about family involvement in the treatment of borderline personality disorder. I hope you enjoyed tonight's webinar, and please type in your questions as soon as you want. Thanks.
Thank you, Chris, and it's really my pleasure to be here. Welcome all of you to this really wonderful webinar series. I'm delighted to be a part of it, and I think it strives to increase awareness education and diminished stigma. As many of you know, the psychiatric diagnoses are stigmatized most among all medical diagnoses, and among psychiatric diagnoses, BPD is among the most stigmatized. And I think because of this, there's been a reluctance at times to make the diagnosis, to teach people about the disorder, or to raise awareness. There was often a belief that giving a person the diagnosis doomed them and discouraged them, and that's really an old way of thinking, and we're trying to reverse the trend where we now make the diagnosis as early as possible and encourage people to seek treatment. As you know, many people with BPD, and most of the people we see at McLean, are multiply diagnosed with other disorders, including depression or anxiety, substance abuse, eating disorders, or trauma. And there's been a tradition of diagnosing those disorders, but really neglecting the underlying personality disorder, which in fact, if untreated, makes these other conditions much less amenable to treatment. So it's very important early on to make the diagnosis and offer one of the empirically validated treatments for BPD. Much of the work that I've done at McLean has been dedicated to raising awareness about personality disorders, doing consultations with cases that were described as treatment resistant or failing to respond to traditional treatments, and learning that there was an underlying personality disorder that was not being addressed. Unfortunately, a lot of the theoretical approaches to understanding the psychological aspects of BPD have led people to either blame the patient for having BPD or blame the families for causing BPD. And I guess the biggest message that I want to convey tonight to the listeners are that families do not cause BPD. Families are not the problem. Families are one of the most important solutions in the treatment of BPD. And an involved, engaged family is one of the best prognostic indicators for someone to make a better recovery. Very important, because there is certainly a tradition of talking about the invalidating environment as an etiology for BPD, and also the crazy-making relationships with family members that can cause the disorder. What I do believe is that there is an underlying biological vulnerability that is not fully understood at this point. I think that there is an evolving awareness of the neurobiology of BPD, but it's very limited, and our best understanding is that many of these traits are heritable, they're familial, but not transmitted in any of the more robust genetic patterns. So I think that's very important to understand. In terms of an invalidating environment, I would say the world is an invalidating environment, and no one makes it through their life unscathed. Most people don't make it through their families unscathed, but we know many families where one individual has BPD and other siblings or family members that had the same parents or were raised under very similar conditions don't have BPD. So there certainly is a way to understand the impact of an invalidating environment, but association does not imply causation. And I think that it actually interferes with the treatment process when people feel blamed for the disorder. I see many families where everyone feels intensely guilty. And, I often feel that people are all feeling guilty, but no one is to blame. I like to start by saying to families that you may not have caused this problem, but there's so much that you can do to help your loved one recover and overcome the symptoms associated with BPD and heal the family. Because the disorder invariably affects the whole family needs treatment as well. And that's a crucial part of the more comprehensive treatment of BPD. I tend to think of the person with BPD as the most sensitive or vulnerable member of the family, kind of like the canary in the coal mine. The person who's likely, if there is family stress, to carry that family stress or to carry the affect or the emotional valence within the family. They can also be the rebel. They can be the oppositional or defiant individual who's saying the system isn't working for me. I've got something to tell you about how it's not working for me, and you need to hear me out. So there are these presentations, and they're both important and worthy of evaluation and understanding. DBT is one of the primary evidence-based treatments for borderline personality disorder. In the Borderline Center at McLean Hospital, we offer a number of evidence-based treatments. DBT is probably the most famous and highly regarded of the treatments. It also requires a lot of training and skill on the part of a clinician. It requires a community of clinicians to conduct a consultation team. So it's not an easy thing to do in the community. It's not an easy thing to do outside of a large academic center. But it's a powerful treatment, and it's an effective treatment. And it's really based on the concept of validation. Validation is the sine qua non of DBT. And the idea is that the therapist creates a validating environment for the patient that emotionally corrects the invalidating experience that they've had in their life otherwise, and that this is part of the healing process. DBT describes three parts of validation. First is acute listening, undivided attention in taking in the individual's story and hearing their concerns. The second part is an accurate and non-judgmental reflection back to the person, as in, do I have this right? Did you say this? Am I understanding you correctly when you express this? And then the third is the actual validation. And that's what's unique to DBT and what distinguishes it from cognitive behavioral therapy. Otherwise, it's where cognitive behavioral therapy emphasizes empirical refutation or logical arguments. DBT emphasizes validation. Validation is, with change, the primary dialectical core of the treatment. And there's a theoretical understanding that until someone can achieve an acceptance of their experience, of their understanding, they're not able to make change. And the treatment is balanced on acceptance and change. The change being problem solving, usually, although there are other methods. So in working with families, it's very important to teach families how to validate. Families have to learn to validate themselves, and they have to learn how to validate their loved ones. And part of this is done through a foundational psychoeducational process where you teach me about your loved one and you give me that story, and then I teach you about the disorder, and we put our heads together and think about validation strategies and what seem to be the primary areas of difficulty within the family. We see so many families here who are so dedicated, have made enormous sacrifices for their loved ones and are very involved in the treatment and struggling to deal with a lot of the more difficult or painful aspects of borderline personality disorders, such as self-injury or suicidality, or the emotional volatility and dysregulation. Validation is concerned with conveying to the patient that their thoughts, feelings, and behaviors are understandable and understood and make sense. And behavior is always valid within the context in which it occurs. And so the task of the therapist and the task of the family, in many ways, is also to find the validity within thoughts, feelings, or behaviors. Now, sometimes that's easy to do. Sometimes that's like finding a marble in a cup of water. Sometimes it's like finding a needle in a haystack. And maintaining a non-judgmental and validating presence and listening position in the work for the therapist and her family is part of the ongoing process. And part of what we do in the consultation team is prompt each other and give each other feedback when we're slipping out of that validating mode. My experience in working with families for over 20 years is that the best outcomes, the most successful outcomes, where we see a fuller remission of the disorder occurs when there is active family participation and integration of the family work into the treatment. The family work varies based on the presenting clinical circumstances. It might be a few meetings with a clinician. It might be weekly coaching. It might be daily coaching and multiple times a day coaching, depending on the level of acuity and distress of the family system. It might be some education and guidance. It might be a more formal family therapy where people are sitting in the room. Usually something like that wouldn't occur till much later in the process because most patients at the start of treatment don't have the skills present to be able to use that kind of format. So that's a more advanced treatment. Part of the program is to really evaluate the patient and the family's need for clinical involvement and to titrate it as appropriate. So thank you for listening. I'm interested in hearing your questions and looking forward to having a dialogue with you about borderline personality disorder and the dilemmas that families face.
Great, thank you. Thank you so much, Dr. Flores. That's a very helpful introduction. But again, we're really looking for questions that all of you are struggling with. So please type them in now. You'll see the Q&A box in the lower right-hand corner of your screen. So type in as many questions as you want. But we've already got several in queue. The first one is a question that very often comes up, and I think it's worth repeating and getting different opinions. So the first one is about what causes BPD. Are people born with it, or do life circumstances cause it? There's certainly literature and other sources that suggest that maybe trauma causes it. So what can you tell us about the cause of borderline personality disorder?
I would say multifactorial is probably the most accurate and honest at this point. As I said earlier, there is a neurobiology, and we do think that there's a biological predisposition. And invariably, when I've met family members or extended family members, we might see one who has a trait or a couple of traits but doesn't meet full criteria for the disorder, or a family member who has a few of the traits but has no significant impairment associated with it, that it's quite adaptive and they do quite well in their life and it hasn't really interfered with their life. And then people that have some of the traits who are profoundly incapacitated. So it's obviously a complex disorder, multifactorial etiology, with an underlying biological predisposition. There are some interesting studies coming out of Hamburg about the role of oxytocin in the etiology of BPD. There are no primary pharmacologic treatments that address this specific neurotransmitter, but it's something to think about for the future. As many of you know, there's really no pharmacotherapy that primarily treats BPD. We treat the associated conditions. With respect to trauma, it's a unique circumstance, and there has been a long-standing debate in the field, I think related to some of the stigma attached to the diagnosis, where a group found the label pejorative and have advocated for a label of complex trauma. And certainly for people that have complex trauma, their presentation can look like BPD. It can look like many other varied psychiatric diagnoses, but one of the presentations can look like BPD. And the treatment approach would be the usual treatment for BPD, but depending on the acuity of traumatic symptomatology, that part might have to be on hold while there's a more specific treatment for the trauma. There are variations of DBT developed by Edna Foa for specific traumatic symptoms related to BPD.
Great. So a related question while we're on the topic. What if somebody with BPD wants to have a child? Are there any special considerations in terms of the pregnancy, or is there an increased risk of mental health problems in that child?
It's a very interesting question, and something that we're trying to get more data around. In our program, there are a number of young mothers, and this, of course, is a huge worry for them. And I think there is really not robust data that would suggest that one should not have a child in the presence of BPD. I think that there is stronger evidence for the heritability of depression or bipolar disorder or OCD. Generally, the most significant issue of consideration is the emotional stability of the mother and the safety of the mother, and understanding the specific challenges attached to parenthood.
Okay. So moving on, I think the next big topic, and at least 3 or 4 people have asked related questions. But so let me start with overall. What do you do if you have a daughter or a loved one who you suspect has BPD, but is refusing treatment?
Interesting and challenging. You know, we generally see that people with BPD are suffering and struggling in such a way that they seek out treatment. And many inpatient populations, partial hospital populations, a significant percentage of these patients have BPD. So the usual profile is someone, especially if female, someone who seeks and accepts treatment. The occasions where someone resists treatment, in my experience, have often been related to comorbid substance use and a worry that there might be a recommendation to come off substances or go through a detox, or in the cases of trauma where there's a fear of revealing a secret or a fear of what the consequences might be of telling the story. So I think the family has to probably seek treatment for themselves first, Psychotherapy isn't really something that can be conducted involuntarily because it requires so much effort and so much investment, so much hard work. So hard enough to do when you're highly motivated, and probably impossible to do when you're not motivated. And there might be different approaches that one would take for the reluctant patient. So first, I would say the family to get treatment and get some coaching and guidance about how to approach their loved one, and then to think about a treatment approach that is maybe less intensive but becomes an effort at initial engagement of the patient. Dr. Gunderson's treatment of good psychiatric medicine, GPM, is such a treatment and is meant to be available in non-academic treatment centers, places where there aren't a vast number of specialists. It involves largely a case management model, not an intensive psychotherapy model, but can be a good way of introducing someone to treatment and the treatment process that might help them work on some of the issues that are causing them the most distress.
So to follow up, I'm going to give you a slightly more difficult scenario now. Add a layer on top of it. So this is from a person who says we're trying to decide how much material or financial support to provide to our young adult daughter who has borderline personality disorder, who is neither employed in school nor in therapy. She's gotten many jobs, but never lasts long enough to collect a paycheck. Do we minimize material support so as not to insulate her from the consequences of her choices? Or do we continue to fully support her so as to reduce her stress and in recognition that her inability to work, stay in school, or do therapy might be symptoms of her illness?
Very good question, and an important dilemma that I see from mount up. First, again, I would say that as a family, as parents, you should seek treatment by a clinician who's familiar with working with BPD to give you some very concrete and specific guidance that is tailored to your daughter's specific circumstances. One of the recent developments in the Gunderson outpatient program, as of a few years ago, was the requirement that people take on 15 to 20 hours of paid or voluntary employment. A lot of the data coming out of Mary Zanarini's lab showed that the vocational rehabilitation process was really insufficient. And even when people had made fairly robust clinical recoveries, they didn't necessarily go on to become self-supporting or weren't able to manage a job. So we feel that doing it as part of treatment is absolutely essential. And I think the task is to, of course, remain supportive, but to make support contingent upon the person making choices. So if we get back to the concept of validating, you want to validate very specifically, even if behaviors are valid, you don't necessarily want to validate them. You validate that which you want to see increased and that which you view as positive. So you have to find the areas where there is clinical progress or improvement or behaviors or styles of interaction that are positive or healthy or progressive, reflective of improvement, and then you want to validate. So I think it becomes a primary therapy issue, which is to say, we love you, we want to help you, we want to see you do better. You have to also take responsibility for improving your life. We want to be a part of it, but you need to do the following in order for us to help you. So for every family, it's different, and it depends on the environment. But I think that support needs to be made contingent upon the person participating in treatment and interacting with the family in a way that feels healthy and progressive.
Great. No, I think that's very helpful. The next question is about siblings who have been hurt by their sibling with BPD. So do you have any suggestions? I'll read you the scenario. Do you have any suggestions for helping our 24-year-old daughter repair relationships with her siblings? So much damage has occurred over the years, especially with her 18-year-old sister, who was subjected to her rage since she was young. They understand her diagnosis on an intellectual level, but don't really care about it on an emotional level. How can we foster a better environment for all of these people who are all still living at home? Her sisters don't want to participate in family therapy, as the focus always seems to be on the patient rather than on their experience.
Very important and frequently observed phenomenon of family members and siblings feeling traumatized by the experience. And a familiar situation of siblings being reluctant to go to treatment because it wasn't their fault, or that the treatment gets commandeered or feels improperly focused. I think that's part of what is so essential about a separate family clinician, so that the identified patient can have his or her own therapist and do that work, and the family can have their treatment and make sure that these issues get properly addressed. Depending on the degree and severity of the relationship and whether it's impacting the siblings' ability to live their life or to have relationships, that person may have to seek individual treatment and may need some primary treatment focused around the impact of having a sibling with BPD. That might need to be separate from any kind of family work. It's a long process, but in terms of being able to improve or work through the issue, it really requires engagement in a therapeutic process. When the identified patient gets better, there's often an effort to re-engage family members. And my experience has been overwhelmingly that if the person is able to make progress and demonstrate a different mode of interacting, a different way of being, and if the sibling has their own support and adequate education and the ability to validate an empathic understanding of the process, there's mutual empathy, that resolution of these issues can occur. Unfortunately, that sometimes doesn't happen, and I've seen families where there's ongoing estrangement between siblings or other family members, and it's an evolving process.
So I want to push you a little bit on this. Could you give us, because I'm going to assume that these siblings, I'm going to take this participant at her word and assume these siblings are going to refuse to go to their own individual treatment. They're going to say, we've had enough of it. It's not our problem. This is her problem. She needs to grow up. She needs to apologize. She needs to behave, or you need to kick her out or something. Like, I'm only 18, she's 24. Like, let's get rid of her. Why are you allowing this chaos in our house? So let's assume that the siblings are going to refuse any treatment. So your first recommendation is they should maybe get family therapy or their own individual therapy or something to help them figure out how to solve this dilemma. But what would you do if you're the parent and those siblings who presumably don't have a psychiatric diagnosis and are behaving themselves reasonably well and being cordial at least, but then are in a way the victims of these rage attacks? What would you suggest to the parent? what should the parent do with that dilemma? Because I'm putting myself in that parent's shoes. I've got a disabled 24-year-old daughter who's clearly struggling, but I see that she's really damaging relationships with these other people, and she's really behaving inappropriately at times. And then I've got my other children that deserve equal love and attention, and they're sick of it, and they're not going to go to therapy. They've gone to therapy already, and they're not going to anymore. And what do I do as a parent?
It really is a difficult dilemma, and there are many scenarios like this. I think depending on the toxicity of the environment in the home, it may be that the person diagnosed with BPD has to be put in a residential setting or has to leave the home for one reason or another, but that may be the only solution, is actually separating and putting the person in a therapeutic clinical environment. The dilemma then occurs if the person refuses that, the family is then left struggling. And many of the core symptoms of the disorder make it very hard for an individual to separate or live independently. So there are many different levels of residential treatment. We're fortunate at McLean to have the Gunderson residence, which is a high-intensity residential setting where the person is immersed in multiple evidence-based treatment approaches, but it's primarily a DBT-oriented program. And it takes the person out of their home, out of their usual milieu, and out of the family system in order to impose intensive treatment. And there are many other less intensive residential settings that can accomplish something similar, especially if there's a sense that siblings are being harmed. Parents will have to enforce something like this if there's violence in the home. That's an absolute indication that someone should move into a residential setting. I would say for someone who's that out of control and at home, you would really want to get consultation around the treatment, and is the treatment sufficient? Is the person getting the kind of treatment that they need? If this kind of behavior goes on and you don't see any evidence of improvement, you should get more consultation.
Great. No, thank you. So I think a related question. So somebody else asks, how do you deal with rage attacks? How do you deal with seemingly unwarranted anger, accusations, blaming, many family members, not all, but many family members have experienced this at least once. And what are some guidelines for how they can react and be more helpful, both in the moment and then maybe, the next day or whatever?
So one of the inherent vulnerabilities of someone with BPD, and this gets back to the etiology of the disorder, is that the person is exquisitely emotionally sensitive and reactive. They're interpersonally very sensitive. So it takes very little to trigger a strong emotional response. And the strong emotional response, once triggered, doesn't diminish in the usual time frame. It lingers and lingers and lingers and might go on for many hours or even days. So that's the classic profile of BPD. We do think that there's an underlying neurobiology that explains this. And the result is often clinically manifested as emotional volatility or rageful outbursts. So in terms of the person's individual treatment, that's what we would call a target behavior. And it becomes a primary focus of treatment where there's a detailed analysis of the precipitants and the emotional process that produces that kind of rage. So I think when this occurs, I'm assuming the person is in treatment and this is a known clinical issue and it's being worked on at some level. So if that's the case, and it's happened before, usually families could say, this is familiar, there's a plan in place. So usually the person will have developed with their therapist a behavioral plan in advance of an absolute outburst of rage. And usually the goal is to intervene before the volcano explodes, but sometimes that isn't possible. And so there usually is part of a plan that would give guidance and advice to families about what to do once the volcano explodes. Another strategy might be that if there's a family clinician involved, that would be a time for the family to page the clinician and get some coaching and guidance around what the best interventions and strategies were, what the precipitant was, and what might make a repair likely, or what might allow the person to quiet down. And sometimes these things are very simple and concrete and common sense, like you have to go for a walk, or you have to leave the house, or go into your room and listen to music, things like this. But they need to be determined in advance, because at the moment of a crisis, it becomes really impossible for someone with BPD to access their executive skills and their problem-solving skills. So it needs to either come from the family or from the clinician in advance. So it's a common treatment issue, and it's something that we look to target. Sometimes rageful outbursts can be modestly responsive to certain medications. Sometimes that's a possible intervention. Usually at that point we would try implementing behavioral skills when we see the escalation occurring. So the clinical task is to really intervene earlier, before the volcano explodes. And as families become more educated and aware and knowledgeable about the disorder and the specific precipitants to such behavior, they can often intervene or subvert this kind of explosion through thoughtful and mindful interventions.
Okay. So I'm going to ask a separate question, but come back to these rageful outbursts. So a couple of people have asked for more information on what is validation. So one person says, how do you validate ideas that don't really make any sense? Another person says, does validating mean you're actually agreeing with the BPD symptoms? So let's take maybe one of the more extreme examples, these rageful outbursts. What would validation look like? Could you I know there are thousands of scenarios, but could you give us maybe one example of how a family might be somewhat validating in the context of a rageful outburst?
Really good question. And validation is a difficult concept to fully grasp. And it really requires, I think, an ongoing dialogue with the treater and going through lots of different scenarios and rehearsing validation strategies. But, and again, we don't want to validate because it reinforces certain behaviors that we want to see extinguished. So there are certain behaviors like rageful outbursts or self-injury or suicidality that get hugely validated by the environment. For instance, if someone goes into the hospital, that's very validating. It's very reinforcing. It behaviorally does the opposite of what we would want to accomplish in therapy. So we really have to kind of rewind a little bit and go back to can a family intervene at an earlier level? Validation at its core conveys that the person's experience, their thoughts and feelings and behaviors in the moment as they're experiencing them make sense and can be understood and are understandable. So one of the challenges is if family sees this as, oh, this is so crazy and out of the blue, I have no idea how you got there. So part of the work in a family treatment is to go through in a more methodical way what might be underlying it. And that means really knowing your loved one well and understanding what the actual emotions are that are underlying it, and trying to gain a greater understanding. So the first level of validation is just listening and attending, taking it in an undivided way where you're not looking at media, you're not on your cell phone texting, you're really listening to the person. The second is thoughtful, non-judgmental reflection. So it might be something like, what I heard you say was this. What I heard you say was that you felt I was not paying attention to you when you were trying to tell me something that happened today that was important to you in therapy. Is that what you're saying? That's what I heard. Is that what you're hearing? Is that what you're saying to me? And checking it out with the person. And then the actual validation that occurs is, it would make sense to me now that you would be upset or angry that I wasn't paying attention, that this important thing was happening, and that in the past when I was too busy with my job or preoccupied with other things, I wasn't available to you in the ways that I needed to be or should have been. Now, you can't do that kind of validation when a person is in a state of extreme dysregulation. It has to happen at a more calm and quiet moment. All behavior is valid at some level. You can also validate by speaking the unspoken with someone, like, I know you didn't do well on your test today and you studied really hard. The person says, oh, I really don't care, it doesn't matter, it's a stupid class, I don't care if I fail it. Well, I know you enough to know that that would matter to you and that it would be upsetting to you to have not done well in that class. So it's kind of the hermeneutics of everyday life, or the hermeneutics of suspicion. Like, I would feel bad if I prepared for that class and didn't do well on the exam, and that empathic resonance with a person is another level of validation. A different level of validation might be something like, well, you were really trapped at that party with your friends who were making you drink and kept filling up your glass with beer, and I know you had said you weren't going to drink, or you were just going to have one beer. So even though you know that drinking too much is ruining your life, I could understand why it was hard for you to not drink at that party. So you don't validate that which is invalid. Validation does not mean agreement. It means comprehension. Meaning, it makes sense to me that given the circumstances and given who you are and given your life experience, that you would have fallen into peer pressure because you want to be part of that peer group and you wanted to fit in, And so you didn't care that you were on medicines, and so you did something like that now you're paying for. So again, it's you can't, validation is not agreement, it's not making the invalid valid. A different level of validation would be based on behaviors in the moment, similar to this other circumstance, but we think about it with respect to certain things like self-injury, where again, you don't want to advocate, you don't necessarily want to validate, but because you'll be confronted with it, you have to find a way of talking about it that is non-judgmental and validating at some level. So it might be something like, I understand that you are in so much pain sometimes, and you feel so alone or unloved or so bad about yourself that you can't go on. And the thing that gives you relief from your emotional pain is if you inflict some physical pain on yourself. And I can understand how, because we were on vacation and your boyfriend was out of town and your sister wasn't talking to you, and your therapist was unresponsive to your page, that it felt like you couldn't do anything else to comfort yourself. So even though you know that self-injury doesn't help you have a good life and that it sets you back in terms of your long-term goals, I could understand how in the moment you were in such desperate, dire straits that you had to get some kind of relief. Another higher level validation is characterized as radical genuineness, and part of it can come through as cheerleading, which many people can find invalidating, but it's often easier for parents to do than for patients to hear or accept. But it's kind of recognizing the validity of the person, the talents, the potential, the traits that you find loving or adorable, valuable in the person. When you can say, well, I know you since you were born, and I know that you're a fighter and that you can get through this and that you can find a way of conquering this difficulty. And I believe in your capacity to do that. So it's more about validating the person as a being, as an equal, as someone with potential and future.
Okay. So the next question is, we've actually had 3 or 4 people ask about how to deal with lying. And one person says, my daughter lies all the time about all sorts of things, and how can I be more helpful? Another person says, my daughter won't allow me access to her therapist, and she often lies about how things are going and fails to tell me about major catastrophes or ER visits or other dilemmas. Another person says, my daughter will say things that my husband and I never said or did to her. And how do you validate something that's not true?
It's an interesting dilemma, frequent, common dilemma. And I guess I would start by saying that the field is really evolving toward a more dimensional understanding of personality disorder. And we're now trying to identify the specific personality traits that are most disabling for people. So we're probably going to move away from BPD, paranoid personality disorder, obsessive compulsive personality disorder, narcissistic personality disorder, antisocial personality disorder, and develop a profile that actually descriptively suits an individual. And the lying part is really important. It may be an antisocial trait. And antisocial traits in some ways are a negative prognostic indicator with respect to treatment. And part of that is because the inherent efficacy of psychotherapy is undermined if someone's not honest. But there may be other explanations. Sometimes people that have a severe personality disorder have a factitious disorder, which is they are either making up or saying that they have certain psychiatric symptoms or that they were harmed in one way or another as a way of getting care. So part of it requires a clinical assessment of what the purpose and the motivation is behind the deceit. Is it a distortion, as in, my mom's always mad at me, or is it an outright lie intended to elicit a certain response from a treater or to retaliate in one way or another? So it requires a careful analysis. I always think that families know at some level when they're being deceived, and it has to be something that gets talked about, and there has to be an awareness. I think it's of limited value to try to prove that the person's lying, even though sometimes we have to do that in order to keep people accountable. It is in DBT and in all of the psychotherapies an issue that is taken up as a primary issue in the treatment. It's especially challenging, and I think it's part of why the family needs to have a voice in the treatment. It's important for families to know that even if you're not allowed to talk to the therapist can listen to you, and that's not a violation of confidentiality. So getting your voice in the treatment is important. Getting your voice into the treatment through a clinician who's dedicated to working with you as a family is even more effective. And we have to understand what the impediment is to greater communication. But that would be an active issue someone would be taking up in the therapy.
Great. So a more generic question. This person says her daughter is starting the BPD year-long treatment program here at McLean. Can you tell me more about it? But I'm going to rephrase that. You can speak a little bit about that, but can you tell us maybe more about, just generically, what does treatment of borderline personality disorder look like? And any generic tips on how family members, a spouse, can be helpful in the treatment?
Sure. So McLean has Borderline Center, and the Borderline Center has many component parts. So I'm the director of the Gunderson Outpatient program, which is a private pay and insurance-based program. So we call it a hybrid program. The Gunderson Residence is a fully private pay program. And then we have two clinics, a DBT clinic that is entirely insurance-based, that is a training clinic, and an MBT, or mentalization-based clinic, that is insurance-based. So we have a wide range of services, and the program is growing, and hopefully we're going to have a GPM clinic at some point in the future. When someone enters the Gunderson Outpatient program, my first task is to assess their level of care and whether they need a residential setting or not, and whether they're adequately motivated for treatment and appropriate for treatment on an outpatient basis. I then have to determine what therapeutic approach might be most effective. And that really depends on the presenting symptomatology. We get a lot of people that have had many months or years of DBT treatment and remain highly symptomatic. And in that group, I might choose a more dynamically oriented psychotherapy, or I might recommend a mentalization-based approach, or a GPM approach if the person has trouble actually using a psychotherapy and knows the skills but is just resistant to implementing them. I also identify a family therapist who will work with the family. There's a case manager who will coordinate the care, and we provide a series of groups that are in a really eclectic way effective in treating BPD. So even though these treatments are evidence-based, I would say that the Gunderson Outpatient is an eclectic program that draws from many different theoretical perspectives. And my personal belief is that the best treatments are eclectic, because there's no one approach or model that really is comprehensive enough to adequately address all the issues a person brings or a family brings to the table. So the person might get assigned to anywhere from 7 to 10 hours of groups, and then is expected to find 15 to 20 hours of paid or volunteer employment. And that's for a minimum of 6 months.
Okay. So with that, unfortunately, we're going to have to end because it is 5 o'clock. And I'd say unfortunately because we have lots of questions that we just didn't have time to get to. I want to thank all of you, though, for your time and for your questions. I hope that this was helpful to you. Again, our next webinar is in just a couple of weeks on Thursday, May 12th. We're going to be discussing symptoms of borderline personality disorder in adolescents. In order to register, you can see it right on your screen right now. You can go to that URL and go ahead and register right now. And please spread the word and let anybody else that you know who is affected by borderline personality disorder know about these webinars. I want to thank Dr. Flores for his time and expertise tonight. And with that, I will wish you all good night.